Good morning. Welcome to another session of short course in clinical epidemiology. Today, as you are probably aware, we are doing a series on core grade, and we have completed a few sessions on the same. Today, we'll be having a continuation of the same, and Dr. Reba will be presenting. And we are privileged to have Professor PRATHAP THARYAN, sir, former founder director of PROF Cochrane Southeast Asia, and sir needs no introduction. And we are pleased to have sir to moderate this session. So welcome to all the in-person participants as well as the online participants who have joined online. And without any further delay, I'll hand over to Dr. Reba. Thank you.
Good morning. For today's short course in clinical epidemiology, we'll be looking at the part 3 of understanding the core grade approach. So for the past 2 weeks, we've been looking at the core grade. It synthesizes the most important essential components of the classical grade approach, which helps us to conduct and evaluate systematic reviews. We learned how we can use it to formulate questions to identify the important outcomes and how to rate the importance of the outcomes, how to synthesize the evidence, and how to summarize the findings. And the importance of core grade is it helps us to evaluate the certainty of evidence. From the guideline point of view, they use this overall certainty of evidence, which will directly feed into the way they formulate the recommendations. Of course, there are other things that they consider like resources, feasibility, and acceptability and equity. And based on it, they formulate recommendations, either strong recommendations or conditional recommendations. We learned how randomized studies start off with a higher certainty of evidence, how observational studies start off with a low certainty of evidence. And we looked at the 5 domains which can rate down the certainty of evidence: the risk of bias, imprecision, indirectness, inconsistency, and publication bias. And there are 2 domains which can rate up the certainty of evidence, which is the dose response as well as large effect. We have already covered imprecision and inconsistency. The first and the second paper were covered in the part 1, where we looked at the overview as well as the imprecision. Last week, that is part 2, we looked at the third paper, assessing inconsistency. This week, we'll be looking at the fourth as well as the fifth paper. So the fourth paper covers rating the certainty of evidence, the risk of bias, publication bias, and reasons for rating up certainty. The other 2 lectures are actually found in our CU CMC Vellore page in the YouTube, and the link to the videos is as follows. So let's go on, core grade 4. So let's start off with the risk of bias. So what is bias? A bias is a systematic deviation from the underlying true effect of an intervention on an outcome of interest in a given population. The importance of bias is there in this quote from Aristotle. The least initial deviation from the truth is multiplied later 1,000-fold. So this actually tells you how important a small bias could be. To help you understand further, this is a good example. Imagine you're a ship that's the result of your meta-analysis. The bias is like a wind which actually pushes the ship away from your true target. So bias can actually push it way away from the original true estimate. So what causes a bias? So there can be limitations in the design and execution of your studies. And if a well-done systematic review would have actually instituted safeguards to prevent the bias. So what are some of the biases which are seen in RCTs? So you can have a selection bias. That means there's a bias allocation to the intervention groups. So a safeguard for that would be to randomize. Performance bias is when you give extra treatment maybe to the patient with the intervention arm as opposed to the control arm. That is co-interventions. So to prevent that, one safeguard would be to blind both the caregiver as well as the patient. A detection bias is the way you actually assess the outcome. To prevent that would be to blinding the outcome assessor. And another cause of bias is attrition, the way you handle your loss to follow-ups. To prevent that would be to actually do an intention to treat analysis. So when you look at a systematic review, you have studies which are both high risk as well as low risk of bias. So the first step is actually to segregate these studies into either low risk or high risk. To help you do that, there are already a lot of instruments available to assess the risk of bias. Common ones which we know is the Cochrane's original risk of bias tool, and we have a revised version of it which is called the ROB tool. And other checklists are the Clarity checklist, the CAS checklist, which all our postgraduates are very comfortable using. We have the Joanna Briggs Institute checklist. There's a National Institute for Health and Care Excellence checklist. There's a Scottish Intercollegiate Guidelines Network checklist. And the newest kid on the block is the Risk of Bias Instrument for Use in Systematic Reviews for RCTs, which is called the Robust RCT, which was actually brought out this year. If you look at most of these checklists, the problem is they have individual tools which actually look for imprecision as well as inconsistency. And you understand that co-grade itself has a different domain for imprecision and inconsistency. So the problem is you might double count imprecision and inconsistency. That's why the ROB2 as well as the robust RCT are superior, because they have been designed to use for co-grade. Now, the most important outcomes which all of these tools cover would be issues with inadequate generation of random allocation sequence, inadequate concealment of allocation, not blinding the participants, the healthcare providers, the data collectors, the outcome assessors, as well as the data analysts, and missing outcome data. Variably, what each of these tools capture would be maybe imbalance in the co-interventions, the difference in outcome assessment or data collection between groups, maybe differences in the follow-up time, frequency, or intensity of outcome assessment, deviation from the intention to treat analysis, selective outcome reporting, and early termination for benefits. So these domains, a few of the checklists actually capture. I'll just talk about the ROB2 tool. So you have a version which came out in August 2019. That's the current version. We also have a version for cluster randomized trials as well as crossover trials. So if you look at the entire randomization process, the first important thing is to actually random allocation sequence and concealment. So this is actually covered in one domain of the ROB2 tool, which deals with risk of bias due to randomization. The next step in your RCT is giving the intervention as well as the comparison. And the important safeguard here is to blind the participants as well as the investigators. So this is captured in the domain 2 of the ROB2 tool, which looks at risk of bias due to deviation from intended intervention. The third important thing is you should, the omissions from analysis. So this is captured in the domain 3, that is risk of bias due to missing outcome data. The fourth domain is deals with measurement of outcomes. The safeguard is blind assessment. And the last is reporting, how honestly you report your results. And that is captured in bias and selection of the reported outcomes. So these are the 5 domains which is there in ROB2. So if you look at how it goes, it's a very sequential and very algorithm-based tool. So you have a first question, is allocation sequence concealed? If yes, the next question is allocation sequence random? If no, you would rate it as some concerns. So you follow this algorithms. So you have this algorithm for all the 5 domains. I will not go in detail of each. If you want further information on how to actually apply this tool, we already have multiple videos in CEU YouTube website, where we've seen how to apply ROB2 for a crossover trial, for a network meta-analysis, as well as a cluster randomized trial. We've also shown how to use Clarity tool for risk of bias and cohort studies. The next tool is the robust RCT trial. Robust RCT checklist. So this came out in 2025. The way they have designed it is similar to why they designed co-grade, to keep everything very simple. So here you have 2-step approach. You're going to tell the reader what has happened in the study, and then you give your reason for your judgment. Okay, and here you have totally 6 domains, very simple domains. First is random sequence generation, allocation concealment, blinding of participants, blinding of healthcare providers, blinding of outcome assessors. The outcome data is not included in the analysis. You also have about 8 optional items which you can use. If you look at the first one, the random sequence generation, here the step 1 directly feeds into step 2. For example, was the allocation sequence adequately generated? If yes, automatically your judgment will become definitely low. That is also the same for allocation sequence, concealment, sorry. Now for item 3, blinding of participants. So where participants blinded? Suppose I say probably no. Why do I say probably no? Because there's no explicit statement about blinding of participants. Then my next question is, will this really affect your bias? Now, for example, if I have a trial where I'm looking at 2 surgeries, maybe for a fracture fixation, my outcome is at the end of 3 months, how is the radiographic union? Does it really matter whether the participants were blinded or whether the surgeons were blinded? It doesn't really make a difference, because finally the outcome assessment is going to be by the radiologist. So in this case, participants blinded is no, but I would say definitely low as my risk of bias. So similarly for the other items also, you have 2 steps. And the last item, that is outcome data not included in analysis. Here in robust RCT, if you have less than 5% missing data, it's called low risk of bias. If you have about 5 to 10% missing data, it's called probably low risk of bias. 10 to 15% missing data is probably high risk of bias. And more than 15% missing data is called as high risk of bias. And the interesting thing about the tool is it comes actually in an Excel sheet. So the domain is on the horizontal axis. You can list your studies in this column, and the individual outcomes you want to study also you can list. So if you look at the difference, ROB2 is very structured, it's very signaling, question-based algorithmic judgment. It's more detailed, and it's actually, many users find it difficult to apply. But on the other hand, robust RCT is very pragmatic, it's very simple to apply, it's Excel based, and it's designed to be reproducible. But the only problem is it's not yet available for cluster RCTs as well as crossover trials. The one thing I want to highlight was both these tools highlight that even if there are some problems with your methodological safeguard, it might still lead to low risk of bias in some cases. Let's take an example. You have a trial. So they've done randomization, but there's low loss to follow-up, but they've unblinded. Suppose you're looking at mortality outcome, which is an objective outcome. In this case, the risk of bias will be less affected because mortality, nothing can be changed. But on the other hand, if your outcome is pain outcome, and you're going to capture pain by using the visual analog score, if the participant is unblinded, they might actually inflate their pain rating. So in that case, you might have a high risk of bias. Okay, so now we move on to risk of bias in non-randomized studies. So we all know RCTs have the best body of evidence. So when do you actually look at observational studies for intervention? Sometimes you might, for your target PICO, you might not have an existing RCT, or you might have an RCT which has very low quality of evidence. In that case, you must actually look for NRSIs. So non-randomized studies of intervention as a class of study design has a very low certainty. Why? Because you don't have randomization. And you need randomization to match your unknown confounders. So if you look at a cohort study for an NRSI, you look at two cohorts, patients who have got a treatment, patients who didn't have a treatment. You see how many of them developed outcome, how many of them didn't develop an outcome. You can also have a case control study design where you look at patients who had an outcome, patients who didn't have an outcome. You go back and see how many of them had a treatment, how many of them didn't have a treatment. Now, this NRSIs have a lot of intrinsic bias. So one of the main biases is you don't have there's different eligibility criteria for selection of participants. So you might have some confounding. For example, if I'm a practitioner and I want to give a new drug, I might not give that drug to a patient with a mild disease, or if my patient has a lot of comorbidities, I might not really end up giving the drug. So you can see that the patient I don't give the drug is very different to the patient I might give the drug. So that's a problem with NRSI. You can also have inaccurate measurement of interventions. And for example, suppose I'm doing a registry cohort and I want to see how many of the patients have got a PPI. In the NHS, if you've been prescribed a PPI, it's there in your drug database. But what about the patients who have taken over-the-counter PPIs? What about the patients who've been prescribed PPIs but have not been adherent to it? So you can have some inaccurate measurements of intervention. You can have inappropriate measurement of outcome. There can be inadequate control of confounders, either in terms of inaccurate measurement or adjustment. And like RCTs, you can have missing outcome data as well as selective outcome reporting. Now you also have some tools which helps you to assess risk of bias in NRSIs. Commonly, what we use is Newcastle Ottawa Quality Assessment Scale. There's a clarity group modification for cohort and case control. And the new one is the Robbins I, which is risk of bias in non-randomized studies of intervention, version 1 and 2. Just briefly about the Robbins I tool, you can look at the website. It's right under the Rob2 tool. So you have the original version and we have a newer version which has come out in 22nd November 2024. So if you look at what is important in the Robbins tool, it actually it helps you to first identify the confounding factors. So once you have identified the confounding factors, it asks you 3 signaling questions. That is in B1. Did the authors make any attempt to control for confounding? And you can put your answer in that. The second question is there sufficient potential for confounding that an unadjusted result should not be considered further? The third question is, was the method of measuring the outcome inappropriate? For these 2 questions, if you rate it as yes or probably yes, you stop the entire scoring. You say that this study is at a critical risk of bias and you don't have to go further. Suppose you have you are of an opinion, okay, the risk of bias is not much, then you can proceed. Then you go on to your risk of domains, which are 7 risk of domains, and similar to the Rob2, you again have a lot of signaling question and algorithmic approach. And finally, you rate your study for each domain for low risk of bias, moderate risk of bias, serious risk of bias, and critical risk of bias. So if you look at co-grade, they start off all their NRSIs as low quality of evidence. Then using these 2 tools, that is the Newcastle Ottawa quality score or clarity score, they can upgrade your, if there's any problem, the risk of bias, you downgrade it even further from low to very low quality. But if you're using Robbins I, you can see that the baseline confounding is already taken care of in Robbins I. So the first part. So if there's a lot of confounding, we don't proceed with the risk of bias tool. So if you're going to apply Robbins I tool, you can take your NRSI as a high quality of evidence and then rate it down for the risk of bias. But why do teams find it very difficult to use Robin's eye tool is, one is, you can see, the usability is poor, the questions are misunderstood, instructions are unclear, and overall application is quite demanding. So we've covered RCTs, we've covered NRSIs. There's one more methodology where you do look at single arm trials. Now, for example, you have patients, and from the patients you bring out an experiment group, and you give the treatment for all the patients in the experiment group, and you don't have a control. That is called a single arm trial. Why do you think this usually applies? Yes, this usually applies in the cancer population. So what happens is, what you can do if you look at a single arm trial, you can never be sure of the effect of your intervention because you don't have a contemporaneous comparison. But what people do is they can actually look at your historical cohort and see what was the survival in these patients when I didn't give this intervention, and look at your trial data and see what was the survival. But we cannot do a proper adjusted analysis. So always these type of trials always have a high risk of bias, and your certainty always comes down to very low certainty of evidence. The only place where there is an exception is when you're looking for harms. Sometimes when you do a particular intervention, the adverse effects are only specific to the intervention that you use. For example, you undergo surgery. Suppose I did a cholecystectomy, all my post-op complications are only occur if I had undergone cholecystectomy. It doesn't happen if I in the general population. So for example, you're doing the colonoscopic audit for the month of October, and you find the risk of bleeding is 1.64 per 1,000 patients, and the risk of perforation is 0.84 per 1,000 patients. But in a casualty, how many patients do you think actually come with intestinal perforation? The incidence will be very low. So in that case, you can actually say that this evidence is good quality. So when you're actually segregating trials as high risk and low risk, it's a very difficult way to actually segregate it, because it requires a lot of close calls, because nobody actually knows what is the threshold to overall rate a study for low risk and overall rate a study for high risk. For example, suppose in my risk of domains, there are 7 domains. One domain is high risk of bias. Do I rate the entire study as high risk of bias? Some authors might take 2 domains. If there's high risk of bias, they might overall rate the study as high risk of bias. So that is one thing to remember. The other thing to remember is risk of bias may be different across outcomes in the same study. I'll give an example. So this is a systematic review looking at IL-6 blocking agents for treating COVID-19. So out of all the studies, just want to highlight one study. This particular study, if you look, there is some problem in the measurement of outcomes. There is some concerns. So the overall risk of bias, they had given it as some concerns. Now, one of their outcomes was clinical improvement. So here's the study, and this is the result of the study. And look at the risk of bias. They had given it as an overall risk of bias. Why? Because there was some bias in the way the outcomes were assessed. Now, the same study has looked at the all-cause mortality. And look at this D-clerk RCT. Over here, what happened to the overall risk of bias? It's written as very low. So you can see that how the same RCT in 2 different outcomes has different risk of biases. Now, finally, that you've segregated the trials as high risk and low risk, how do you overall rate your evidence, your systematic review? So first question to ask is the evidence dominated by high risk of bias studies? Suppose almost 60% of your weight is coming from high risk bias. The next question is actually to use the results of all the study and rate it down. There is one nuance here, which I'll explain. That is the direction of the bias. Suppose all your evidence has low risk of bias studies. That is more than 40-50% is full of low risk bias. Here you can have 2 options. You segregate them as high risk of studies and low risk. See their individual results. If they both are matching, you combine everything and don't rate it down. But if you find both are not matching, you take the evidence only from your low risk of bias studies. Okay, here's one example. So here they've done a systematic review. In a condition called chronic periodontitis, they have looked at the benefit of giving adjuvant antimicrobials, that is azithromycin, plus the scaling and root planning, which is a standard of care, versus scaling and root planning. So for this particular comparison, they had 4 studies, and they got an effect of -6.65, which was favoring the intervention. Now, if you look at their forest plot, for chronic periodontitis, they had 4 studies. And look at the Han 2012 study. You can see this is a very low risk of bias study. What about GOMI 2007? It has a high risk of bias. What about this LIAW, which is also high risk of bias? And the fourth study also here has a high risk of bias. You can see that actually all the high risk of bias outweighs your low risk of bias study. And you have got a final outcome. So here how the authors dealt with this is they pooled the entire effect and then they downgraded it for the certainty of evidence. There's an another nuance if you have a lot of high risk bias, like all your studies have high risk of bias. So here you not only look at how much bias is there, you also have to see which way is it pushing the result. Okay, I'll show you an example. Suppose you have a study which is looking at a drug versus placebo for pain relief and osteoarthritis. Now the outcome is patient reported score in the visual analog scale. And it's an unblinded trial. What do you think the result of the study would be? Will it favor the drug or will it be against the drug? It will favor the drug. So here you'll know that the bias will actually favor the drug. Your true estimate might be this, but the bias has favored the drug. So for this study, would you downgrade for risk of bias? Yes, we will downgrade. We will look at another example. Primaquine versus no primaquine for prevention of Plasmodium falciparum. Here the outcome of interest is adverse effects. And here there is lack of blinding. What do you think patients would attribute all their nausea, vomiting, diarrhea to the primaquine? So do you think the overall effect will favor the primaquine or will it be unfavorable to primaquine? It will be unfavorable. So you're actually expecting the bias to come here. But interestingly, if you look at the outcomes, it was actually favoring the primaquine. The result of the study showed that primaquine had less adverse effect. But your bias would have pushed it against primaquine, but your study result is showing that there is a benefit with primaquine. So here you can be very confident that your true estimate that the incidence of adverse effect will actually be much, much, much lower in primaquine. So here will you rate it down for risk of bias? Here you will not rate it down for risk of bias. So you understood the importance of actually looking at the direction of bias, not just looking at the overall amount of bias. So that deals with the risk of bias. Now we'll go on to the next, which is the publication bias. So what is publication bias? So there is bias in the pooled estimate of effect that results from failure to publish studies based on the results, typically studies with negative findings. So here, where do you think the bias will push the effect to? It will push the effect to favor the drug because all your negative results would not have been published. So why do you think there is selective non-publication of studies with negative results? One is the authors themselves feel very discouraged seeing negative results and they feel like the journalists will not publish it. Second thing is journal editors and peer reviews, indeed, they will not publish negative results. And the third thing is commercially funded studies will try to suppress your negative results. So I'll show you a classical, very interesting example of this. So there was this drug called reboxetine, which was actually recommended for acute treatment of major depression in the European countries. So this was a systematic review actually published by from Germany. So what they looked at was, but they had realized that in America, the drug was not actually approved. The FDA had actually rejected it. So they did a systematic review to actually look at all the published as well as the unpublished data. So if you look at it, they have looked at 4,347 records they had identified after excluding duplicates and screened the records. They finally got about 10 studies from the bibliographic database. They have mentioned in the study, retrieval of previously unpublished trial was hampered by the fact that during preparation of the preliminary health technology assessment report, the manufacturer of reboxetine did not provide a complete list of unpublished trials. Okay. Then after that, what they did is, after the publication of preliminary report, the manufacturer decided to cooperate and provided most of the missing data. So even though they had 10 studies, they actually had evidence that at least 16 trials, including reboxetine, was there. So they had pushed the manufacturers and finally the manufacturers gave their data. So overall, they had about 17 studies. So now look at this data. So this is looking at reboxetine versus placebo. This is looking at reboxetine versus selective serotonin reuptake inhibitors. These are the published studies and these are the unpublished studies. How much is the published study? Just 1. And how much is the unpublished studies? 6. What's the patient population in the published study? 126 plus 126. What about the unpublished study? It's 1800. So almost 86% patient data was not published. And in the reboxetine versus selective serotonin reuptake inhibitor group, 67% of the data was not published. And look at the report of the published data. It's showing a fantastic result with reboxetine, showing some 2.51 odds ratio. But actually, after combining the data, does it show any benefit? It shows no benefit. And similarly, with reboxetine versus SSRIs also never showed an initial benefit. So this is a classic example of how unpublished data completely changes your opinion of a drug. This was another study published in NEJM, which basically looked at the publication of antidepressant trials. So the FDA had this was actually done in 2008. So by 2008, there were 74 antidepressant trials registered in FDA. FDA had said, had deemed 38 studies as positive. So if you look at all the 38 studies, whatever is in light gray is actually published. Whatever is in dark gray is not published. Out of the 38 studies, how many were published? 37 were published, only one was unpublished. Now look at the ones with questionable as well as negative results. Almost 36 trials were negative. And out of it, 22 were not published. And 11 of them were published as if the result was positive. Here, the good thing was the authors who did these systematic reviews, they actually had data for the unpublished studies. So they could establish that the results had been overestimated and they had definite evidence of publication bias. But sometimes, as review authors, you are aware that eligible studies exist, but the results are not unavailable. So the results are unavailable. So what do? So you actually look at the registries and look at the sample sizes of those studies which you don't have the access to. If you feel the sample sizes are too high, you can rate down for publication bias. You might have another scenario where you have really no clue whether any studies exist at all. In that case, you look at the studies, and if all your studies are small, if all your studies are sponsored, then you should also rate down for publication bias. So how to avoid publication bias on the part of the author is you have to do a comprehensive search. You must look at non-index as well as non-English journals. You have to look at all the study registries, and you should also look at regulatory databases for looking at the pharmacological data. Suppose you're suspecting publication bias, what you can do is look at funnel plots as well as statistical tests. Some of the statistical tests available is the Eggers regression test and Beck's rank test. Now, this is a funnel plot. It's called a funnel plot because it looks like an inverted funnel. So if you see, this is the overall effect, and these points are the individual study, the magnitude of their effects. And on the y-axis, you have the study precision. As you go up, your study is more precise. So usually the largest studies are on the top and they're more closer to your overall effect. And your smaller studies are on or lower down because the confidence interval will be higher and they'll be more further from the overall effect. Now this graph is not suggestive of a publication bias because you have small studies on either side of the graph. That means you have small studies for positive effect as well as negative effect. But here you actually have to suspect publication bias because you find one quadrant missing. Why is that? Why is there no small studies with negative results? Either there is a publication bias or the small studies were biased so that all of them are favoring interventions. So this is just an example of probiotics for acute infectious diarrhea. You can see that all the small studies are favoring the probiotic and there's only one study which is not favoring the probiotic. So this is actually a publication bias. Now there is one more aspect to it. It's called a selective outcome reporting. Sometimes you find that in the protocol they have outcomes, but in the final study, they might not have reported those outcomes. So this will actually come under your publication bias. Sometimes studies have reported the outcome, the protocol. Your study will also have that outcome. But if you actually look carefully, they might have used multiple available effects. The best effect they might have reported or at multiple different time points. Like last time we were appraising a journal where we saw maybe at 6 months there was a benefit, but at 12 months there was no benefit. The study might push saying at 6 months there's a grand benefit. But actually, if you look at 12 months, there might not be any benefit. So that actually should be picked up under the risk of bias domain. So how to go about the overall rating? You look at whether all the studies are small and industry sponsored. If yes, rate down. If no, you look at the funnel. You look at the funnel plot. If there's any visual asymmetry, you rate down. If not, you don't rate down. If you have less than 10 studies, look at the documentation for unpublished studies. If there are a lot of unpublished studies, you rate down. If not, you don't rate down. And finally, you word it as, if you have no publication bias, you say it as undetected. If you have publication bias, you say strongly suspected. So now we have covered risk of bias, we have covered publication bias, and now we look at rating of certainty, that is how to upgrade the evidence. So first, we actually upgrade evidence only for observational studies and not for randomized studies. The next thing is, to upgrade for observational studies, you must make sure that they have first not been downgraded. Only if none of the studies were downgraded can you actually upgrade. So the first one is, if you have a large magnitude of effect. For example, if your RR or odds ratio is more than 2 or less than 0.5, you can rate up by 1 level. If it's more than 5 or less than 0.2, you can rate up by 2 levels. There are other times when you can rate up. For example, if you have rapidity of onset of action, like we all know insulin rapidly reverses DKA and adrenaline rapidly reverses anaphylactic shock. In that case also, you can rate up evidence. Sometimes you know that if you don't give an intervention, there's a rapid downhill trajectory. For example, hip replacement for a severe hip OA. Sometimes you have interventions where you don't have to conduct a study because the benefit is so good. For example, CPR for a cardiac arrest, dialysis for an end-stage kidney disease, and volume repletion in hypovolemic shock. The next reason why you upgrade evidence is for dose response gradient. If you find incremental increase in the dose or magnitude of the intervention, that causes an incremental increase in the effect, then also you can upgrade. A classic example is in this BMJ by Dr. Richard Doll as well as Bradford Hill, where they looked at the mortality of lung cancer based on how much the person has smoked. The more than a person has smoked, you can see that the mortality has gone up. But you must understand that not all dose responses are causal. You must look for confounding factors before you actually rate up. So for an example, this was a study which actually told that coffee is associated with pancreatic cancer. So what they did was, they looked at the patients who had never smoked. They also looked at the patients who had smoked. And in both of them, you see that the more coffees they drink, the more is the incidence of pancreatic cancer. So actually, the study was later refuted. Multiple studies could not replicate this benefit, and they found that actually coffee and cigarette smoking was a confounder in this design. So that sort of like summarizes your core grade 4. In supplementary appendix 2, they have an alternative conceptualization where they say you can rate up the NRSIs based on your magnitude as well as dose response initially, and then you rate it down for the 5 risk of bias domains. It has some advantages, but the core grade they have put this approach only in the main body. If you're interested, you can read up from the supplementary appendix 2. So that covers our core grade 4. Here we will take a 2-minute breather.
Does anybody have any doubts about what she's covered? So first is risk of bias. So do you have any doubts about assessing risk of bias on one study and then across the studies for that result? Any doubts on that? So the point that she stressed is that, and the tool stresses is, risk of bias does not mean there is bias. Right. So how do you know there's a risk of bias? Because previous empirical research on various aspects of conducting a trial have shown that if you don't generate this random sequence well, and if you don't conceal selection bias. So first question is, when you're assessing risk of bias in an individual study, you have to ask yourself, why do you randomize? You want to balance confounders, known and unknown confounders. But people often forget that selection bias is also influenced by another aspect of the term random. Random means unpredictable. That is why you have to conceal allocation. So nobody who is recruiting patients should know what that patient is likely to get. So that's why we say randomization consists of 2 stages. One is generating a random sequence. Now, you may find when you're doing a systematic review, you will find some studies which are labeled as, they will say, systematic review authors will say, we excluded pseudo-randomized trials or quasi-randomized trials. So what do you mean by that? What is a quasi-randomized trial? So a quasi-randomized trial tells you something that is not properly randomized. So what it basically means is that you use the method of randomization, which generates a random sequence, but you cannot conceal that sequence. That's what it means. So give me an example of what would be a way of generating a random sequence which cannot be concealed. Yeah, alternate days, anything which people know in advance, this is the randomization sequence, though it might fulfill the purposes of randomization to some extent, you cannot conceal it. Right. Now, when systematic review authors say that we excluded quasi-randomized trials, one of the things you should look at is how many of the excluded studies were excluded because they're quasi-randomized. Because if there's a substantial number, I would say that is biased. Why? Because if you look at the risk of bias judgments, they said if it says they use the word random, your judgment according to this is what? Probably no risk of bias. So they have not described how they randomize. You're saying there is no risk of bias. When they describe how they randomize, you're saying there is risk of bias. That is bias. So the advice is, ideally, you should not exclude quasi-randomized trials. You judge them down. And then, whenever you're doing a sensitivity analysis, or if you want a subgroup analysis, you'll say, a priori, one of the items I will look at is risk of bias. So that gives you nuances which these things don't really tell you. Great. So judging each study itself is a problem. Then you have the whole issue of across the studies, how do these risk of bias? So I've got 2 studies at risk of bias and 4 studies not at risk of bias. And the pooled estimate says it's very effective. Least estimate is more than 30% reduction. Now, how do I know I can trust all this? Because 2 of them are at high risk of bias and 4 are not. So you got to first ask yourself, what is the outcome? If the outcome is something objective, then you got to look and see which domain is the risk of bias at. So you have to know much more nuanced, not just say there is this, but say this outcome is death. And 2 of these studies at high risk of bias actually they were unblinded studies. But blinding does not affect death. So I don't need to downgrade. So you have to make those judgments. So the problem with the earlier version of ROB1, ROB2 was we were rating each study across outcomes. Although Revman gave you the option to break up each of the domains into multiple bits. So even in the old tool, you could have broken up blinding of any amount of people. But people would just say blinding and for all outcomes. So what ROB2 is doing is, and the subsequent versions are doing is, they're breaking down the blinding segments into every aspect of it. So you can prejudge. You can say, I want to assess blinding for subjective outcomes and objective outcomes. And you must say, which are the subjective outcomes, which are the objective outcomes. That will help you when you're doing a grade assessment. The second thing to keep in mind is, there is a term which said the preponderance of evidence is from studies at high risk of bias. What does that mean? Preponderance, is it numerical? Really what you're looking at is how much weight do the studies which are at high risk of bias contribute to the overall pool result. So you can have 4 studies at high risk of bias, but each study only contributes 1% or 2% to the overall risk. And you've got a very effective estimate. Then even if you take off those studies, it's not going to change the estimate. So that is what you have to look at when you're looking at preponderance. Is not just numbers, but what weight do they actually give? And if I were to subgroup them, would it make a difference? So when you're grading, you're doing a subsequent assessment. In a way, it's almost like if the authors had done it, then you have no problem. But if they have not done it, then you have to do a post hoc. I'm going to assess and see, do I overall rate down the whole thing by saying, there is studies which are high risk of bias and these are subjective outcomes and they are blinded. But did they actually make a result? You subgroup and you find there is no difference between unblinded and blinded studies, you will not downgrade. So what ROB does is, it helps you out by saying, ROB2, it's not asking you to judge each study. It's asking you to judge the risk of bias for the studies in every outcome. So I've got a study which is contributing to 4 outcomes. And in each outcome, this study is there in many other studies. I am going to rate that study for that outcome separately. So you're basically doing multiple risk of bias assessment per each outcome that the trial is doing. That's more convenient to do when you're doing a meta-analysis. I want to know among the studies contributing to the outcome, what is the overall risk? So that's the advancement that ROB2 is done. It's looking at it saying outcome-based risk of bias, whereas the earlier version was doing study-based risk of bias, which could be used this way, but then you had to break it up into multiple components. Okay, and as you pointed out, it's always good when you're having grade, if you generate a forest plot with the risk of bias estimates, then it becomes easy to. That's risk of bias. What is the other thing? Publication bias. Yeah, so one of the things that didn't come out very clearly here, the use of funnel plots. So the conditions are one, ideally you need more than 10. Preferably around 20. Then only you can really assess the so suppose you find that there are some small studies are not there. What does it mean? So you've got a pooled estimate. The line of no difference may be here. Your pooled estimate may be this side or that side of it. And then you're expecting that you'll get a funnel. The assumption there is in the fixed effect model, what you're doing is you're assuming that the study works exactly the same across results across all the trials, and any change you have there is basically just random, any difference. So in that model, what you do is the studies which have got narrow confidence interval, which means it's got a large sample size and it's got a high baseline risk, will naturally have lower variance, which will translate into narrower confidence intervals. Those studies will have more weight. That means the pooled effect estimate will be influenced by them. So therefore, when you're looking at the top of the funnel, all the studies at the top will be what? Studies with narrow confidence intervals, therefore large sample size and event rates, right? And by play of chance, the smaller studies with wider confidence interval fall this side or that side. Now, if the small studies are not there, that estimate will move. That's what you're trying to detect. If the small studies are not pulling it down, like you showed in your riboxetine, unpublished small studies, they will give you a balanced result. If they are not there, they'll give you an overestimate. That's what you're trying to detect. So there itself, you have to ask yourself, the condition for assessing a forest plot, one, there should be enough trials to give you symmetry on both sides. Two, there should be no heterogeneity. If you're using a random effects model, what happens? The weights are more evenly given. So then you cannot expect to find a random plot. There are many other reasons why you can get an asymmetrical forest plot. So automatically you cannot consume that. For example, high risk of bias studies. They will also give you very effective estimates. No? So those are the caveats for interpreting a funnel plot. Okay. So the best estimate is to make sure have you searched everything. Then the other thing you have to look and see how many studies have you excluded, on what basis. That could be another reason why actually there is publication bias. Third reason is you've got a lot of studies which you have put in your thing saying awaiting assessment. Right. Or you look at the trial registry and there are 24 more studies, results will be out soon. There is also clearly evident that there's publication bias here. Okay. This is just some caveats. Any other doubts?
Doing this in duplicate will be quite a task. We say we are going to do risk of bias assessment in duplicate for every outcome.
Right. Ideally, that's what should be done, which means that you will do and I will do. And if you're using things like covidence, it catches you out because you pre-assign raters. It will tell you this fellow has not completed his rating. And moreover, it will tell you where is the disagreement and you have to make a decision. You have to decide what, is it high risk, low risk or unclear. So those are good ways of trying to document your thinking process and documenting saying this is the reason why we made our mind. So the more transparent systematic review is, the more likely the guideline developer is going to say, okay, I will not have to do my own assessments because my doubts have all been answered here. Thank you.
One comment or question from a participant. If all the findings of our study are showing positive effects, such as in case of an already established antihypertensive drugs, there may not be publication bias in such scenarios.
Possible, they may not be. If you're finding that there already is good enough knowledge and you found a few more studies, the chances are saying we are not aware of any other studies. So, but if you can justify that I have done all the database searches, I have looked at the abstracts of these studies, and then I've actually read the abstract properly, not just looked at the title. For example, you can find studies which tell you the effect of duloxetine in thing, but you're actually interested in some other drug. Unless you read the study, you may not know it's a 5-arm trial. They included that arm, but they only talked about duloxetine. So if you've been thorough, then you will not miss a thing. Yeah. ICMR gives you a project and they specify the search database. So you should actually ask ICMR, what is your logic for searching only these databases? And if they say, we know from evidence that very few of these studies are published there, and usually they're not much, you will have to make a decision, right? So somebody assessing your review will say they only search 3 databases. On Amstar, they'll cut you down. Right. So the fact that your funder asks certain things is not necessarily all you have to do. If you're being fair, you should ask him to justify why. As long as you can justify why I'm only searching these databases, it's fair. Any other one more? Did that answer the question? Okay.
They want a revision of the methods to downgrade studies based on high risk of bias. You want to see the flow chart one more?
They want to see it again.
Example in the subsequent. So I will answer that in the second part. So we'll move on. Okay. So now we go on to the core grade 5, where we rate certainty of evidence for the assessing indirectness. So we'll be looking at the types of indirectness, the indirectness concerns for a guideline versus a systematic review author, how to distinguish indirectness from inconsistency, and indirectness that arises in searching for direct evidence versus relevant indirect evidence, and examples of the various sources of indirectness. So if you talk about indirectness, there are 2 scenarios where you actually use it. So one is in terms of indirect comparisons. The other is indirectness related to the PICO issues. When you talk about indirect comparisons, an example would be you're actually looking at you want to find you want to compare A and B, but there is no RCTs which is actually available for A and B. But you have a common comparator C, where you have 3 RCTs comparing A and C and 8 RCTs comparing B and C. So based on this common comparator, you can actually compare A and B. This is what has been employed for more than 15 years in meta-analysis, network meta-analysis, where they look at multiple interventions and multiple comparators. The other indirectness is when you have a specific target PICO for your clinical question, but none of the studies in your review actually match your target PICO. So then you can have indirectness. If you look at core grade, they focus only on this type of indirectness because they're only looking at direct comparisons of single intervention with single comparator, and this is outside the scope of core grade. So we'll be only looking at this. So indirectness is a mismatch between the target PICO and the current best evidence. Sometimes as a trial investigator, you would have planned a study with a target PICO. Sometimes the study you carried out might not be what you planned out. So for example, I had wanted to do a study in both elderly as well as young patients, and I end up getting only maybe low risk patients. I was anticipating a high adherence to treatment. You end up, the patients just don't participate. So low adherence. You're probably thinking in each of my centers, the standard of care is the same. But then in the real life, you might find the standard of care in one setting is very different from the standard of care in another setting. And you might probably have planned for a long follow-up, but you might have to cut short your trial either because of funding issues or because of a pandemic, like what happened in COVID. So that's one. So the next thing is the indirectness concerns also, there's a difference from the systematic review point of view as well as the guideline development. If I'm a systematic review author, I can have like a target PICO, and it's up to my discretion to choose only the PICOs of the studies which actually match my target. So for me, indirectness might not be a major concern because I'm only screening all the studies. But on the other hand, for a guideline developer, for them, they usually have to address public issue concerns of immediate or an urgent need. For them, they cannot actually screen so many studies. They must actually condense the best evidence available for a particular question, even if it's indirect. So for them, they'll have more of a indirectness issues to deal with. Now, I just want to highlight indirectness versus inconsistency. Last week, we looked at inconsistency. We learned how we actually have to formulate broad PICOs and not keep it too narrow. We also learned how it's important to have a plan of action before you do the trial. So you have to anticipate different results, and you should actually generate a priori hypothesis, and you must also postulate your direction. And we also saw how to test the hypothesis. Now we'll give an example. There's Mrs. R who's admitted in C ward with acute coronary syndrome. She gets discharged. How many of you will advise lifelong aspirin therapy for her? All of us. So actually the basis for this recommendation for the lifelong aspirin for secondary prevention is based on historical aspirin trials in 1970. Now that is actually being questioned because now you have PCIs and patients might be on oral anticoagulation. Do you have to give aspirin along with oral anticoagulation? Or if the patients have a high bleeding chance, would you give aspirin? You also have now P2Y12 inhibitors, the Prasugrel, Clopidogrel, which are much better than aspirin. So leave that aside. But let us look at this recommendation for aspirin for lifelong. That is based on trials from 1980. So these are the characteristics of the said trials. You have the mean age, and I want you to look at this column. What do you notice? All these trials have predominantly been done in men, but you're applying this to your patient who's a female. So is that indirectness or not? Okay, you might not really consider it for indirectness because you're probably thinking that aspirin is biologically similar in males and females. Why should that really be a difference? So maybe you might actually not consider this as indirect. Now I'll give you another example. This paper we actually saw in detail last week. We looked at corticosteroids in community-acquired bacterial pneumonia. So here, in this study, they had looked at 18 studies. Here is the study names. Here is the countries they have done the studies in. This is the male-female population. This is the age of the studies. And this is how many of them required mechanical ventilation in ICU. And I wanted to concentrate on this column, severity. So if more than 50% of those trial populations were had a lower score on the curb 65 or the port PSI, they were graded as non-severe. And if they were mechanically ventilated or required ICU care or the port PSI score was 4 or 5, they were classified as severe. So out of the 18 studies, 8 were considered as non-severe and the remaining are considered as severe studies. Now, my question is this. Is steroids useful for patients with community-acquired pneumonia who have mild to moderate disease? Does it reduce mortality? Now, if I look at my overall study result for that particular outcome, what do you see? It's 0.75 and the confidence interval is 0.59 to 0.97, which actually favors the steroids. So here, is there indirectness in my outcome? My target question is what? In low risk, that is in patients with mild to moderate disease, I want to look at the mortality of steroids. But what did the study show? More than 50% of the study was from severe population. So here there's definitely indirectness. Now the good news for us is the authors have had a previous subgroup analysis. So they have actually in their design of the study, they have decided that they're going to segregate severe community-acquired pneumonia versus non-severe community-acquired pneumonia. And they felt the steroids will be beneficial only in the severe arm and not in the non-severe arm. They had also looked at other criteria like whether the high risk of bias is there a different and low risk of bias if there is any difference. Now look at the result of the study. So in the less severe arm, there is maybe about 8 studies in the less severe arm. What is the effect showing? There is no evidence of steroids. This is the most severe studies. What is the overall effect showing? There is an effect of steroids. So they had a subgroup hypothesis and they have confirmed it. Next, what they did is they looked at an Iceman tool and they have assigned moderate credibility to their subgroup hypothesis. And the good thing is they have also presented separately. They have actually presented the mortality data for both more severe and less severe population. And when I'm looking at it, my target interest is what? Less severe. So I looked at this particular row and I found out that there is no benefit of giving steroids. So have we addressed indirectness or not? So here we have addressed indirectness. So this is just an example to show how beautifully the inconsistency as well as indirectness you can actually put it together. The one thing I want to show was this particular thing. Yeah, the mortality, you can see that they have actually downgraded the risk of evidence. Okay, so why have they downgraded the risk of evidence? One is they have said that there is heterogeneity in the way they have classified severe. Some studies have taken ICU and ventilated as severe. Some studies have taken the port PSI score. So because of that, they have downgraded 1 point. The next thing they have downgraded because of imprecision. We actually saw it in the last class how they have downgraded for imprecision. Have you noticed that have they downgraded for risk of bias? They haven't downgraded. So here I will show you. So the same study, they have classified the studies as low risk of bias and high risk of bias. So in the high risk of bias, they find that there is no mortality benefit. In the low risk of bias studies, they find that there is some mild mortality benefit. And how much of the weight is contributed by high risk of bias studies? Less than 50%. So it's predominantly low risk of bias studies, which is 63.73. And what they have done is this. So if you look at the algorithm, is evidence dominated by high risk of bias studies here? No, it's mostly low risk of bias. Now the next question is there any substantial subgroup difference between the high risk and the low risk? So if you look at it, if you look at the test of group differences, P is 0.087, which is insignificant. That means there is no difference. So you don't have to rate down for anything. Suppose there was a difference, what I would have done is I would have taken the benefit, I would have looked at this particular result and taken this for my study. I hope that answers the question on how to downgrade for this thing, risk of bias. Now, the next thing I want to cover is sources of evidence for guideline developers. So as a guideline developer, I might have a target PICO. And when I'm looking at articles for my review, I come across direct evidence. And in those direct evidence, there could be some minor issues. For example, some studies overall match my PICO, but there could be some differences in the baseline risk or comorbidities. But suppose there is a lot of non-adherence to your intervention. If their studies are focusing on surrogate outcomes rather than patient-important outcomes, if there are problematic comparators, then those are major issues even in my direct evidence. Sometimes I might not have any evidence for my study. Then I have to actually look for indirect evidence. An example would be, as a pediatrician, I have acute pancreatitis children. Do I give antibiotics or not? There is no RCTs or evidence available in that group. So I can look at the adult population and extrapolate their findings. So that is called indirect evidence. But then what you should do is you must rate down for indirectness. So it's very important not to conclude that there is no indirect evidence. We must actually search for indirect evidence because some evidence is always better than no evidence. So let's look at one example. We have a guideline question. In pregnant women with COVID-19, does tocilizumab improve mortality compared with standard care? So there are no actual available RCTs for this. So let's look at what the WHO guidelines have done. So overall, in their infographics, they have classified COVID as non-severe, severe, and critical. And the interventions, what they're strongly recommending for. If you see, IL-6 receptor blockers are strongly recommended in severe and critical illness. But this is the general population and not pregnant women. So in the top of their guidelines, they have actually told uncertainties are present. That in immunocompromised in children, in pregnant patients, the evidence is uncertain. But in this particular recommendation, what they've written is, none of the included RCTs enroll children or pregnant people. Although this resulted in uncertain applicability, the guideline development group did not have reason to believe that children or pregnant people with COVID-19 would respond any differently. So here, they've not done a formal certainty rating, but they have described that the evidence is limited in pregnant women, and they have acknowledged the decreased certainty of evidence. So this is what you can do if you have indirect evidence. Now, I just briefly give an example of indirectness in each of the PICO domains. So first is difference in population. So we all know that the differences in age exist between all trials, elderly versus young, adults versus children. The second problem with population difference where indirectness can arise is, what if your target population changes over time? Maybe the study was done in a particular population, but when you're applying it, the population is different. A classic example is actually in the COVID-19. So in 2020 to 21, WHO had actually recommended casirivimab and imdevimab and sotrovimab for COVID. So these are basically neutralizing antibodies which bind to the spike protein of COVID-19. But what happened is, from 2022, what happened? The COVID variant changed. It became Omicron. And the subsequent lineages didn't have this particular sequence. So these two monoclonal antibodies had no effect in the in vitro studies. So what did WHO do? They strongly recommended against casirivimab and imdevimab. So this shows how the original population can be very different from your final population. Next, there can be differences in your condition. So this was a systematic review which looked at mechanical versus bioprosthetic valves in chronic dialysis. So if you look at it, the intervention was mechanical valve and the comparison was bioprosthetic valve. And overall, at the end of 3 years, there was no great difference in the mortality between both the valves. So what do you think will actually motivate a person to choose either of the valves? The adverse effects. You're looking at bleeding. If you're giving a mechanical valve, you'll have to put the patient on anticoagulation. If the patient on bioprosthetic valve, you don't need to give anticoagulation. So they looked at the forest plot for bleeding. And they found out that there was a publication bias. And overall, it was an observational study. It had a very poor quality of evidence. So they have rated the quality of evidence for bleeding, which is the incidence risk ratios around 2.46 as very, very low. One is because majority of studies included had serious risk of bias due to confounding, and publication bias was detected in the funnel plot. So what they did was, the authors have written, given the very low certainty in evidence among patients with dialysis-dependent kidney disease, we conducted a meta-analysis whereby we pooled bleeding reports from 5 RCTs comparing warfarin to placebo in the general population. So they did 5 RCT meta-analysis and they came with a risk ratio of 2.99, and they have downgraded it for what? For indirectness. So here you can see that the population is completely different. They have taken in indirect evidence, but they have clearly mentioned that they have downgraded for indirectness. So when you're looking at this indirectness for harms, it's very difficult to actually capture harms because RCTs, if the condition is rare, you don't have enough sample size actually detected to detect harms. And estimates for harms will have wide confidence interval and will have a lot of imprecision. So here I just want to briefly talk about for interventions, if you already know the adverse effects known in different conditions, like for example, the previous study, you can extrapolate the data for your study and write down for indirectness. And another method of doing it is you pool data from similar situations to improve the overall precision. For example, look at the study. They wanted to study adverse effects related to steroids, but then individually, each of the studies will be quite imprecise. For example, steroids and ARDS, you can look at the confidence interval, which is 0.22 to 2.56. Steroid adverse effects in pneumonia, 0.64 to 1.82. Steroid for sepsis, it's a little bit narrower, 0.86 to 1.39. What they have done is they have looked at adverse effects for each of these indications and they've given a final overall estimate, which is 1.08, 0.87 to 1.34. So you can see that the final confidence interval is more precise. Now going back, so we have looked at the population. Now we will look at indirectness in terms of interventions. So based on the dose of the drug, the duration of administration of the drugs, maybe the route of administration, IM versus subcute, the skill levels of the providers, maybe the same procedure done by one person is superior to the same procedure done by somebody else. Then there is insufficient description of the component of intervention. So for example, cardiac rehabilitation. The cardiac rehabilitation protocol might not be the same in every centers. There could be a wide disparity. So that can also affect your final intervention estimates. And another important thing to understand is non-adherence. So I'll talk about non-adherence. So suppose you have a target PICO. Does treatment A reduce an outcome compared to placebo? Okay, for example, let's look at amlodipine for hypertension. Suppose in your trial situation, you find that your patients are not taking amlodipine regularly. They're taking maybe 50% of the days amlodipine. What happens? There's a complete difference. Now you're not looking at consistent use of amlodipine. You're actually looking at partial use of amlodipine. Does it help in blood pressure control? So you can see that there is indirectness at play. Another example I'll show you. So this systematic review group, they looked at effect of colonoscopy screening on risks of colorectal cancer and related death. So this was a trial RCT. So they want to address a question, is screening colonoscopy beneficial for patients? Should we advocate for universal screening? So what do? They randomly assign the population to 2 groups. One arm would get an invitation for screening colonoscopy, and the second arm are patients who actually need a colonoscopy. And then the primary endpoint was risk of colorectal cancer and related death. And secondary endpoint was death from any cause. So this was called the Nordic trial. They had done the study in Norway, Poland, and Sweden. So they had got about 85,000 patients. 28,000 of them were assigned to colonoscopy. 56,000 were assigned to no screening colonoscopy. And out of this, finally, 28,220 were included in the intention to treat analysis and 56,000 in the this arm. But what do you notice here? If you look at the participants, look at the number of non-compliers. Out of the 22,000, how many of them actually came for the colonoscopy? 16,000. How many of them complied? Only 11,000. So your compliance rate was only 42%. Okay, so participation in screening was lower than expected. Poland only 33% complied, Norway only 60.7% complied. So if you look at your primary endpoint, which is your risk ratio, in the invited group, the risk ratio is 0.82. In your usual care group, the risk ratio was, from 0.98 to 1.20, the risk ratio was 0.82. So there was absolute risk reduction was only 2 per 1,000 over 10 years of cancer risk reduction. And your number needed to invite was around 455. This seems to be a very low number with a low benefit. But if you look at the adjusted per protocol analysis, you can see that the risk ratio was more, 0.69. I'm not asking you to look at the per protocol analysis because it's definitely biased, because we don't know what happened to all the loss to follow-ups, etc. But I just want to highlight that suppose the patients had adhered, you might have got a different effect. So here, what we understand is the trial has not really looked at screening colonoscopy for risk of colorectal cancer. What they have actually ended up doing was invitation to screen. That is a programmatic offer. Is not a guaranteed receipt that the patient got a colonoscopy. Okay, so if you feel that the effect in a fully adherent population would be much, much more than what you got in a partially adherent population, you have to rate it down for indirectness. So if you're a guideline developer and your clinical practice, you're basically developing clinical practice guidelines, would you recommend screening colonoscopy using this particular study? Will you rate down for indirectness? Yes, because there was a lot of non-adherence. But on the other hand, you're a guideline developer for a public health program. And your interest is, if I invite patients for screening, will it reduce the overall colorectal risk? In that scenario, you would not rate it down for indirectness. So actually, point of view is very important. So if RCTs have a higher adherence risk, it is actually not very great from a public health point of view, because they'll be unrealistically higher than what you actually seen in clinical practice. So that will actually come under your imprecision. Oh. So she was asking if a study doesn't really complete its. Oh.
Yeah. So when it means stop, that's it.
Yes. So if it has been stopped because of benefit, this thing that will actually come under the risk of bias. But on the other hand, if you have a small number of studies, then the concept of optimal information size will actually come into play. Then you have to downgrade it for imprecision.
So we stop early. The caution is that if you have a study stopped early, is one reason why you should consider downgrading, but for risk of bias.
In your form, you have
No, that particular study, see, across the outcomes, you've got an particular outcome and you've got 5 studies, right? On each study's domain will be there, on each of those domains. So in the earlier version, under other sources of bias, that will be where you downgrade for incomplete, for cluster randomized trials which have not properly been done. All those reasons would come there. But now ROB2 has for cluster randomized a separate form. So even there, they look at incomplete accrual will come under outcome, incomplete outcome data, because they stopped early for benefit, apparent benefit, which Gordon Guyette says you should not do.
Okay, there's one more problem with intervention population difference. One is, what if the trial actually allows you to switch the treatment? So for example, in malignancies, like metastatic RCC, you have a group A, you actually want to compare interferon alpha with sunitinib. Now, interferon alpha didn't work, so the doctors have added sunitinib to this arm also. So will you downgrade this for indirectness? So the simple answer would be yes, but there is also a nuanced answer to this, which is found in co-grade. So what they say is actually it depends on your target PICO. Suppose you're okay with comparing sunitinib with interferon alpha, provided that patients who do not respond to interferon alpha also are offered sunitinib, then you might not downgrade for indirectness. But if you're very particular, know that you have to compare the two different study drugs, then you will rate down for indirectness. So if the and in here, if the proportion of patients who have switched is large, then your indirectness will also be very large. Now, another thing to understand is what is the apparent effect of intervention? So suppose in this group and in this group, you find that the overall effect is the same. Both results are similar, then you must downgrade for indirectness. Why? Because you don't know whether interferon alpha itself contributed to the effect or whether you have added sunitinib and that has contributed to the overall effect. So for here, you would rate it down for indirectness. But suppose you clearly you get a result that sunitinib is definitely more superior, then you don't have to rate down for indirectness, because even after adding sunitinib to this interferon alpha, you have found a difference. That means interferon alpha is really, really bad. So if you have a clear superiority, you don't have to downgrade for indirectness. So actually in this study, what they had found out was the 1-year mortality between the interferon alpha alone group versus the sunitinib arm. They found that there was a benefit of sunitinib. The risk ratio was 1.3 from 1.13 to 1.51. And so for this, you don't really have to downgrade for indirectness. Another concept with the intervention is sometimes your technologies actually change over time. So if you look at insulin pumps, the insulin pumps of 1980s is not the insulin pumps of 2020. So studies which are compared insulin pumps in this decade is very different from the studies which will compare insulin pumps in this current decade. So that now we have finished examples for population and intervention. Now a few examples for comparators. So sometimes what happens is there is variation of standard care between the jurisdictions. Sometimes studies use placebo when you actually have a active treatment which is clinically relevant, which is available. Sometimes people use older alternatives than current optimal alternatives. For example, looking at antihypertensive studies, many antihypertensive drug trials, they actually compare with atenolol. But we know that atenolol is quite in the sense, we know there are so many more drugs which have better antihypertensive effect than atenolol. So is it justified now to compare a new drug with atenolol? No, we should use a better comparator. Sometimes your placebo arm or your comparator arm, there could be differences in the dose and duration of administration. So this is just a study to highlight that lack of head-to-head trials and fair control arms, RCTs for biological treatment of rheumatoid arthritis. So they've just looked at the trials for rheumatoid arthritis. So if you look at these trials for DMARD naive trials, that means patients who never got either synthetic or biological DMARDs, you can see that they're all comparing all the drugs with only placebo. There are very few trials which actually have comparison with other DMARDs. So this is actually not right, because patient has severe disease. They could have benefited from an approved therapy, but you cannot withhold the approved therapy and give them a placebo while you compare a DMARD. So this picture is also showing for patients who have already got first-line biologics, adding a second-line biological agent, none of the studies have actually had head-to-head comparison with other biologics. They're all comparing with the placebo. So the differences in outcomes. So this is the last part. So impact of intervention versus comparator also depends on what outcomes are measured. Your study result may be very different if you look at symptomatic osteoporosis or asymptomatic osteoporosis. And it's also important to know how those outcomes are measured. Direct measures would be like mortality rate. Surrogate markers, for example, if you want to see whether your antiretroviral drug is acting, you're actually looking at the reduction in viral load. So that's a surrogate marker. Some few other examples of surrogate markers would be for heart failure, patient probably wants to know how my breathlessness will improve. But what you're looking at in your study would be the ejection fraction in an echo. Similarly, for osteoporosis, the patient important outcome would be fractures. But what we're looking at is bone density. For dementia, patient important outcomes would be functionality. But we're basically looking at test performance in scores. And for diabetes, we're actually worried about microvascular and macrovascular morbidity and mortality. Most of our diabetic drugs actually look at the HbA1c level. So surrogate markers might not really translate to clinically important outcomes. So just one example of how to handle situations when available outcomes are only a surrogate. So this is a study which looked at percutaneous mitral commissurotomy versus surgical commissurotomy for rheumatic mitral stenosis. And look at the grade summary of findings table. So their outcomes was symptoms and heart failure due to mitral stenosis. as inferred from mitral valve area at 30 months. So they had told that the patient important outcome was symptoms and heart failure. Their surrogate outcome was the mitral valve area. They felt if the mitral valve area is larger, the patient would have less breathlessness. They found actually no benefit. But look at the quality of evidence. They have rated it down, one for imprecision, one for inconsistency, and they have also rated it down for indirectness, as mitral valve area is a surrogate marker for improvement in symptoms and heart failure. So it's important to downgrade for your surrogacy also. So just to summarize, the PICO element, there is you can have indirectness in the population, the intervention, comparison, and outcome. Indirectness in population would overall cause only low likelihood for rating down. Why? Because relative effects are typically similar across populations. In the first week, we saw how even the populations are different. The relative effect more or less tends to be similar. So the overall rating down might not be much for population differences. But intervention differences, you'll have an intermediate likelihood of rating down because it depends on whether the patient, whether there was non-adherence, whether there was switching of trials. For comparisons, there's a substantial likelihood of rating down. Because if you actually have a very effective new treatment which is available and you don't use it, you use a placebo, definitely your effects would be different. And outcomes, there's a very high likelihood of rating down for indirectness. Because a lot of studies which have looked at the same drug for a patient outcome have found inferiority as compared to looking at surrogate outcomes. So with this, we have actually looked at all the domains for rating down for risk of bias, and we've also looked at domains for rating up the certainty of evidence. And next week, we'll actually look at how to formulate the grade table as well as how to move to guideline recommendations. Thank you.